great honor for me to introduce Professor Attilio Di Spiezio. And my job is very easy. Everybody knows him. And so Professor Attilio is the chief of hysteroscopy department in Naples. And a long story. So I think that it's better that he start the session.
Again, thank you very much. So I'm happy to see that even the last day the room is quite full. So it means that thanks to the great speaker that they were before and will be after me, so the attention does not go down. So I'm very happy of that. This is a sponsorized lecture, so that's why when you see the conflict of interest, but even it's important, a good message, even when you do a sponsorized lecture by a company, I never allow, as the speaker I've seen yesterday, to review my slides. And personally, apart than one, I know I don't use the slides provided by the company because I think it's always important that you critically analyze even what the company gives to you. We are going to speak about medical therapy. If I have to define medical therapy for the treatment of myoma, is the Cinderella of the available treatment that we have. At least it was like that in the last, I would say, 15, 20 years. We use just for temporary relief of the symptoms when you have myoma to make this myoma better for surgery as preoperative therapy. As you see, the last part as research. So we studied a lot medication, potential medication. And then since 2015, you know the advent of the selective progesterone receptor modulators. Then you have seen the possibility of the antagonist. And we arrived up to the antagonist that we are using now since 2022, that probably has changed the life of many of us, but mostly important, changed the life of our women. So I will going to speak about our personal experience about Relugolix combination therapy. The battery are going down. So this is the slides that I use for the company just to explain in a better way what is Relugolix combination therapy is. So basically it's an antagonist of GnRH receptor. So it's going to bind the receptor of GnRH analog inside the anterior pituitary glands. And so you reduce basically the production of FSH, LAH, you reduce the production of the hormones that have a good effect, positive effect on the growth of the myoma, but even on endometriosis, adenomyosis. So all the hormone-sensitive pathology can be negatively affected, but it means a positive effect at the end for our women. Why CT combined therapy? Because there is an ADVEC therapy inside, estradiol and norethistron acetate. The advantage of this medication is that you are going to take 1 tablet per day, and it works as a contraceptive, so 100%. So this is very important in the counseling with your lady. Say that we are using a contraceptive because you take daily 1 tablet per day, so effective to prevent pregnancy, but has also a positive effect on the symptoms that this lady are going to show. When we use symptomatic uterine fibroids, the reason why I'm doing this presentation, long-term treatment, keep in mind that myoma are a chronic pathologies. They grow up throughout the year, so we need something effective for a long period of time. We can use as pre-surgical treatment, and we can also use for the symptom of bleeding and pain with women for endometriosis and adenomyosis. And another advantage is very important for our lady, that there is the full reimbursability for the indication of myoma, but is going even to be fully reimbursed for endometriosis indication. So it means that even for the lady is not a cost, because there will be the full reimbursability by the healthcare system in the respective countries. But I want to do a more philosophical speech about medical therapy. So we always in the past, even when ulipristal acetate came on the market, we were focused on the myoma. We were impressed by all the great image that Jacques Donnet and others of the myoma shrinking, MRI, transvaginal sonography. But with this new medication, we shift our way of approaching women with myoma. So we understood that we need a more holistic approach to the lady and the symptoms related to the myoma. At the end, the lady doesn't want to know that the myoma from 4 centimeter becomes 3 centimeter if she continues to have the same symptoms of before. The women wants to stay well. It's important, the quality of life. And when we ask women what they want, of course they want to avoid operation. If they have to undergo operation, they want a minimal invasive approach. They want to retain the uterus. Don't say that the woman wants to have hysterectomy. No woman wants to have hysterectomy. It's because we convince women to have hysterectomy. But if you ask women what they don't want to waste day off at work. They want to come back to their family as soon as possible. Here there are a lot of women, probably some of you have myoma, and I think no one, even if you are doctors, wants to undergo surgical operation. So the difference between, I think, this medication and the previous medication, we did even in a paper, so this comparison, like a motorboat, okay, it's feasible, it's nice, so you reach the island probably quickly, but if you go on a sailboat, you reach the same destination, probably in a safer way, probably a little bit longer than the previous medication, but at the end, in a safe and skillful way, you arrive at the end, you arrive at destination. But which is the role of this medication in infertile patients? Because if you look at literature, there are no many papers about that. We saw these slides many times. The mechanism why myoma can cause infertility. And we know, Jamal says before, more the myoma is inside the uterine cavity, more is going to affect the fertility. And if you look at the guidelines, for submucous myoma, there is an agreement. The myoma inside the cavity should be removed, even when the myoma goes towards the uterine cavity, as we are going to see. And which is so the place of medical therapy in this situation. First of all, no randomized trial comparing medical therapy with surgical therapy. But another problem, it's written in this very interesting article, this, when you read papers, keep in mind that surgeons, because all of us, mainly we are surgeons, have a familiarity bias towards surgical therapies. Because at the end, we don't know, it's much easier to remove the myoma rather than trying to understand why this myoma is dangerous, is harmful for our lady. When we see about all these genes or cytokine, interleukin, we get a little bit bored, say, okay, come on, just remove the myoma. And you have to take in consideration why sometimes surgery is always preferred and has better outcomes in comparison with the therapy. In order to be pragmatic, what we have to do, Jamal says before, if the myoma is type 0, type 1, type 2, you should undergo surgery, hysteroscopy, no option, no other option. Even my friend from the talk before says that when the myoma is inside the cavity, better to remove. GnRH antagonists are a good opportunity, and personally, in our institution, we are using, even in this other indication, even when we have type 0 and type 1 myoma, but very big, in order to make surgery easier, because we surgeons want also to deal with myoma less vascularized, with a flat endometrium, and we don't want to have any problems. I thank all my team who reviewed the data of our, I think, one of the large series of this, about this medication. And you see that we used in nearly 40% of the cases before surgery this type of medication, and most of this situation was before hysteroscopic surgery. And we are, most of us, hysteroscopic surgeon. What we want, that the myoma is not very vascularized, that surgery is easy, that we don't have problems when we have to do the dilatation by means of Hagar, and that the consistency is not so flat that we can have difficulties in removing. And with this medication, you can have all these, you don't have all these disadvantages, and so you can work in a better environment. Jamal says before, myoma 2-5, always we speak about this myoma, the myoma that can distort the uterine cavity. Let's give practical example. You have a big myoma, it seems that it goes, Alessandra showed before, towards the cavity, you do hysteroscopy, you see that the myoma is not inside the cavity, but because it's big, it pushes in the cavity. Are you going to do surgery for this kind of myoma? I think even the best laparoscopists sometimes can be afraid because the myoma is closer to the cavity. And we said yesterday, Brunella showed in her talk, that when you do therapy of myoma, even laparoscopy, laparotomy, robotic, even if you don't open the cavity, but mostly if you open the cavity, there is a risk of adhesions up to 25%. So even the best surgeon would avoid this kind of surgery. And so what we are doing in this situation, as this diagnostic therapeutic algorithm recommend. So first you have to evaluate the ovarian reserve of the lady and to decide if ovarian freezing is the first option. But then try to undergo medical therapy for 3 months, and we are using in our institution Relugolix combined therapy, and then see if there is a good response or a poor response. And you see that for type 3 and type 4 myoma, these are the most challenging myoma because they are close to the cavity, but even the surgeon does not know. It's better to remove from inside or from outside from laparoscopy. And you see on Fertility Street, there has been a fertile battle. Many of the protagonists you have listened these days, so they are in favor or against surgery. But what we know is more the myoma is towards the uterine cavity, more is probably to affect endometrial receptivity. OXA10 are reduced in case of type 3 myoma in comparison with type 4 myoma. So the objective of the medical therapy at the end is that of shrinking this myoma, but most importantly, it has to transform type 2 in type 3 and type 3 in type 4. If we are able to do that, we are going to resolve problems of Our Lady. So what we are going to do, for example, in this situation, the case that we saw before, so type 3 myoma, 3.5 centimeter, 2 failed IVF. We are going laparoscopy. I think it's difficult to do laparoscopy in this case, but the IVF center sent to me to do operation. I said, look, 3.5 I cannot remove hysteroscopically, at least not in one surgical step. This is one of the typical situations. You don't see anything bulking inside the uterine cavity. We give for 6 months, in this case, Relugolix. You see that the myoma transforms himself in type 4. Look, as the myoma can also migrate towards the fundus of the uterus. You can transfer the frozen embryo, and we were lucky or probably good in having a pregnancy in this lady. This is another example, type 3 myoma, 3.2 centimeter. So good ovarian reserve. She had spontaneous pregnancy, 14 weeks of pregnancy, gestation. She had, unfortunately, a miscarriage. She has this myoma. Patients ask you, is the reason of my miscarriage or why I had this miscarriage? In this situation, we only say, look, we try to give medical therapy, in this case 4 months. Why 4 months? Because sometimes women want to have pregnancy in a short time, so we don't arrive at 6 months. So it's important that your sonographer is going to see if the myoma reduces its dimension. And what is nice is that while the myoma was type 3, when the myoma shrinks itself, it becomes more intramural. It's not going to collapse in the cavity. It would be the best option because you remove hysteroscopically. The myoma, when it shrinks, it goes towards the wall, and she's trying. And just to conclude, last slide, you know that when type 3 myoma are small, so less than 2 centimeters, so Jamal, I have seen a fantastic video of Jamal, so I don't want to go ahead with this video, but just to know that this kind of surgery is a surgery that not all surgeons can do. That's why I think that when you have type 3, type 4 myoma, medical therapy can represent a good option, because this is a skillful surgery, and even when you do, sometimes you have intravasation in a short time and you have to stop. And if you have to do 2 surgeries, you lose most of the advantages of hysteroscopic surgery. So to conclude, keep in mind that even in case of infertile patients that can have symptoms, and infertility is already a symptom apart that abnormal uterine bleeding, this medical therapy can be an option to make a better uterine cavity of this lady. And keep in mind that most of the time, myoma pathology can be associated with endometriosis and adenomyosis. And with this medication, you can have effect on both types of pathology. Thank you very much.